Good, Dr. Kamal.
We'll go to another session, another bout. Bout number 24. We will have Dr. Vimal Prajapati, Dr. Mukul Oza, Nural Abbas, Dr. Chirag Patel, Dr. Dinesh Joshi, and Dr. Ravi Bhojani. I would like to request Dr. Mukul Oza to kindly introduce our speakers, Dr. Urmil Shah, Dr. Kalpesh Ansora, and Dr. Ashwani Mehta. Dr. Mukul Oza, are you there?
Chairpersons, please introduce all the three speakers, the case, and then the images, and then we go presentation quickly in succession.
Okay. Good afternoon, everyone. Now our next topic is
Yes,
IV
Dr.
antiplatelet.
Chirag, you can introduce.
Yes. Our next topic is IV antiplatelet in the case of acute coronary syndrome. Our first speaker is Dr. Urmil Shah. As everyone knows, he's a senior interventional cardiologist and director at SIMS Hospital. And he has more than 20 years of experience in intensive care in clinical cardiology and invasive interventional cardiology, and special interest in primary angioplasty. Our next is Dr. Kalpesh Ansora, and he's an interventional cardiologist at Sal Hospital and Sanjeevani Hospital. And our next speaker is Dr. Ashwani Mehta from Delhi, senior consultant cardiologist from Gangaram Hospital, New Delhi. So we will start with Dr. Urmil Shah, sir.
Good afternoon, everyone. Can you hear me?
Yes, sir.
Okay. And can you see my slides now?
Not yet, sir. Please upload the slides.
Yeah, I'm just doing it. Hold on for a second. Yeah, can you see now?
Yes, sir. Please click on slideshow mode.
Okay, so good afternoon, everyone. My case which has been given to me is a case study where a patient is a 45-year-old male, diabetic, hypertensive, NT-wall MI. Patient is for the primary angioplasty, and coronary angiography revealed 100% occlusion in the LAD with a grade 5 thrombus. Now, just to understand what is grade 5 thrombus, is basically a complete occlusion of the vessels, and when there is a convex margin and there is a contrast stain which is still persistent in that artery. Along with that, patient also had 80% disease in the circumflex and also in the mid RCA. Ejection fraction was 35%. Now let us understand the quangrelol, which is an important new addition to the antiplatelet agents. Basically, it is an ADP receptor antagonist. It basically acts through the ADP receptor pathway, and it is a little bit similar as far as mechanism is concerned, similar to the available, that is ticagrelor or the prasugrel. But what we have to understand is platelet aggregation. Last thing is GP2B activation, and we have also the molecule which inhibits the final pathway, that is GP2B-3A on the platelets also. Now let us compare the three molecules which has P2Y12 antagonist. As you can see, both the ticagrelor and quangrelor are the reversible agent, and there is no prodrug which is there. As far as the onset of action is concerned, for ticagrelor it is around 30 minutes. For quangrelor it is 2 minutes. It persists for about 3 to 5 days. It persists for about 60 minutes after stopping. And it's an important addition to the antiplatelet agent, I would say. And that is the reason in some of the patients, it is also indicated to use quangrelor. Quangrelor offers an impressive flexibility, as you can see. Suppose by chance the patient develops some complication, we stop the antiplatelet agent and patient surgery can be done without any major problem. That is an advantage. In a STEMI patient, when there is a disturbed absorption, maybe because of cardiogenic shock or something, then you can bypass because it's an IV agent and directly it goes inside the vein. Another important thing is sometimes in a stable patient, when angiography has been done, we don't know the coronary anatomy, then it is also good because by chance a bypass comes, then it's not a problem. But in situations like acute MI, this doesn't serve the purpose. And finally, it is going to be like a bridging between the, when you want to discontinue the oral P2Y2 inhibitor when the major surgery is inevitable and we have to undergo that surgery. So this is a very classic indication, I would say, for P2Y2, for cangrelor. As you can see, suppose the patient is in cardiogenic shock with MI, or there is a heavy sedation, active vomiting, oral thing is not possible, patient on mechanical ventilator, definitely cangrelor infusion is an important agent. At the same time, when there is a deferred surgery, we cannot delay the surgery post angioplasty, say 1 month, or there is a big thrombus inside the artery. Angioplasty has been done very recently, then definitely this may be a good agent when non-cardiac surgery has been planned. There is a nice comparison which has been done with the cangrelor and the ticagrelor. As you can see here, when you give an IV cangrelor, the interpreted efficacy compared to the oral ticagrelor is definitely better, and we can achieve a more platelet inhibition immediately. And that is the reason why this agent has basically come in the market. Limitation of any oral P2Y2 inhibitor, we know: delayed absorption, delayed onset of action, irreversible platelet inhibition, delayed offset of action. That is also very important and may have a drug-to-drug interaction. And that is the reason, if the patient is not being pre-treated by the P2Y2 inhibitor, then a stent thrombosis can be reduced if you give an IV agent, as I have told, which is acting very fast. And here you can see the GP2B inhibitor also is a good molecule in this context. So it's a GP2B inhibitor is a very potent antiplatelet agent. It can cause almost 90% platelet inhibition. The ischemic complications are reduced in various studies clearly, but there was also an increase in the bleeding. So the overall benefit many times was not absorbed. So it is not very commonly used. Another important thing is nowadays we have a very potent antiplatelet agent like ticagrelor and prasugrel, and that is the reason the use of GPI is definitely reduced. But still, it is a contemporary use when there is a large thrombus burden and there is a no slow flow, which is expected while doing angioplasty in a acute myocardial infarction. Let us compare now various GP2B inhibitor with cangrelor. As you can see here, basically it's a competitive inhibitor. That is one, the half-life of all these three molecules, efiximab, aptified, and tyrofibin is long. Tyrofibin is about 2 hours, and this is only 3 to 6 minutes. As you can see here, normally we stop the infusion after 4 hours of time. But if we are giving a GP2 inhibitor, we continue it for a little longer time. As you can see here, when we are giving GP2 inhibitor, we have to be a little careful because we know that it's a very potent antiplatelet agent and the bleeding complications are high. We try to have the ACT value of about 200 to 250, and the dose of heparin is slightly less because otherwise it can cause a more bleeding complication, and repeat ACT measurement is very important. Now coming to our patient, which has been given anti-wall MI, 100% occlusion. Also there is a disease in the circumflex. The class 1 indication, according to the 2017 latest guideline of primary angioplasty, a potent P2Y2 antagonist has to be there. So I would definitely let everyone know that whenever acute MI comes, usually give a second antiplatelet agent, and usually it is a ticagrelor because we want the patient to undergo. It is a class 1 indication, and normally we give before that. So suppose patient come with this condition, I personally believe that definitely a ticagrelor might have been started in this patient. That is one. Second is there is a big thrombotic complication. We can use a GP2 inhibitor. That is a class 2A indication, and that is we have to keep in mind. And the cangrelor, which is the point of discussion at present, is not those patients who has not received P2Y2 inhibitor then and then. But as I have told, class 1 indication, we usually give in all the patient ticagrelor, and even then it is a class 2B indication and not a class 2 indication. So any patient acute 2021 guideline clearly mentioned that loading dose of P2Y2 inhibitor has to be there, and it is reasonable to use ticagrelor or prasugrel in preference to the clopidogrel because we know it is very fast acting and very effective. Now where in 2021 guideline about the cangrelor, as you can see here, whenever there is a angiograph MI with large thrombus, as you can see in our patient, it's a grade 5 thrombus, or we are expecting a no reflow, it is a class 2 indication to use a GP2B inhibitor. As you can see here, if the patient is not taken ticagrelor, then definitely IV cangrelor can be used. And even then, it is a class 2 indication in the recent 2021 guideline. So cangrelor has been approved by this situation, as you can see, basically to prevent the stent thrombosis, not treated with oral P2Y2 antagonists. And we all know that in all patients of acute MI, we always give clopidogrel, and even if the clopidogrel has been given, we give ticagrelor also, and then we normally take the patient for a primary angioplasty. In the European guideline also it has been mentioned, when patient is not being treated by oral this agent, then we have to give an IV Congreloll. Congreloll has been started in 2006, almost now it's 15-16 years. Still it is a class 2 indication, and reasons are very obvious. As you can see, there are certain studies which has been done in past which were stopped prematurely because of futility, no difference in the primary outcome, and that was the reason it was stopped. So that also we have to keep in mind. One study which showed the advantage of Congreloll over other agents were with the clopidogrel. And now we all know that we are not using clopidogrel in acute PAMI situation. We are using ticagrelor. So we really need to compare a ticagrelor with Congreloll rather than this molecule. Now let us compare the GP2B inhibitor. What has been mentioned is, if you use a GP2 inhibitor, the efficacy wise, the Congreloll and GP2 inhibitor are equal. But if the bleeding complication, if you see, it is definitely high with the GP2 inhibitor. And that is a little limitation we have to keep in mind. But we have to understand that these data are not a double-blind study or it's a randomized study. It was a real-world data. Efficacy is almost same with the Congreloll. The bleeding profile and the safety profile has an advantage. So that also we have to keep in mind. Also, we have to keep in mind that GP2 inhibitor was prolonged for a longer time, which is nowadays not required. That is one thing. And second thing is, in this data, eptifibatide was the molecule which was used and which is known to have more bleeding complication in the real-world data. So that also we have to keep in mind. And now what I am discussing is the use of tirofiban. And as I told in the beginning, the heparin dose and the monitoring of HTT is very important when you are combining antiplatelet agent with heparin and Congreloll. This is the very recent study which clearly shown, which is a fabulous faster, which has compared, as you can see here, one group of patients who is undergoing for a STEMI procedure. 40 patients were randomized to Congreloll, 40 patients were tirofiban and the prasugrel. And the purpose of doing this study is to know what is the platelet inhibition, which is achieved at the end of 30 minutes. And as you can see at the end of 30 minutes, compared to Congreloll, the tirofiban was much more effective. Almost 90% platelet inhibitions were achieved. So both are IV molecule. If you compare with the prasugrel, it's an oral molecule. Definitely, it is Congreloll is better than this. But when you compare with the tirofiban, antiplatelet agents are almost similar. So why tirofiban in my patient? Because acute MI situation, grade 5 thrombus. Here I need a very effective molecule, which is, and as I have mentioned, the GP2B inhibitor basically acts on the final step of platelet aggregation. And that is what I really want to achieve. We need a molecule which is quick acting. As I have shown in the 2020 faster fabulous study, it is much better to Congreloll as far as 30 minutes antiplatelet efficacy is concerned. And tirofiban is basically a time tested, and it is according to the guideline. As you can see, the 2021 latest guideline, it is a class 2A indication and not a class 2 indication, which is there for Congreloll. Another important thing is when using in this type of situation, we are much for us. It is more important to have a efficacy, and bleeding risk we may not keep in mind because we really want to get rid of that thrombus. And our patient is young, and I presume that they may not have a very high bleeding chances, and that is the reason why the advantage of Congreloll will not be there. So Congreloll may be a safe molecule, but as far as efficacy is concerned, tirofiban is a good molecule. As I've told, any of the patient who comes with the primary angioplasty, I don't see any patient who has not taken an oral. So if it is not new, then according to the guideline, use of Congreloll is not there. And tirofiban is the better molecule compared to the clopidogrel in this situation. That also we have to keep in mind. When we are giving GP2 inhibitor like tirofiban, we have to be very careful. It should be weight adjusted, heparin dose, and the ACT guided treatment has to be done so that it avoids the bleeding complication in this group of patients also. And at the same time, we like to give Congreloll. Suppose this patient has come to me, which situation I will use a Congreloll. Suppose patients after 15 days or 1 month need a surgery, which is more of a immediate surgery, urgent surgery. Definitely I will use a Congreloll, will stop the ticagrelor or the other antiplatelet agent for 2 or 3 days, will bridge therapy, and then let the non-cardiac surgery being done. Or else if the patient is in cardiogenic shock, okay, not able to take oral tablets, then according to the guideline or according to the classing indication, we have to give Congreloll in this group of patients. Otherwise, there is no major role of this antiplatelet agent. And why not epsiximab? Because it is basically a long-acting. No recent trial has been done up till recently with this molecule after the availability of ticagrelor and prasugrel. bleeding risk is very high, and no data or direct comparison with cangrelor, and it is little bit costly molecule, and many times it is not available also in the present time. So I will not use apixaban in this group of patients. Recently, today morning, I did this case.
Last 1 minute.
Yeah, it's over. This is last one case. Today morning, I did in fuel MI, as you can see here, a very classic thrombus, which has been seen. As you can see, after putting a wire, is still there is a big thrombus which is there. Now, in this type of situation, we really need an agent which is very effective, and we are more concerned about getting a good result. And as you can see here, we need an agent which is very effective, very with the long-term data. And this is the last result. I've used tirofiban in this patient, and as you can see, the last result is absolutely fine. Thank you very much, sir.
Now we speak to Kalpesh. Urmil Bhai, kindly be with us. We will have a discussion afterwards.
Yes, sir. Yes, sir.
We wish to hear so many things from you.
Yes, sir. Nice to see you, sir.
Yeah. So
Sunday afternoon, still morning.
Your look has changed so much.
Yeah, we are not mad since long.
Dr. Kalpesh. Dr. Kalpesh.
Yes, sir. I cannot share my content, sir.
Neelam? Darshan, if you can help us.
There is option of photo.
Sir, there is a option.
Dr. Shah will have to stop sharing, then the other speaker would be able to do it.
Kalpesh, sir. Hello.
Yeah.
Yes, sir.
Yes,
you can share your screen. Just open your presentation. Then after come back to Zoom window. There are this green icon, the share screen. Click on that.
There is a share content. Okay.
Yeah.
There is option
content.
is photos. I could drive. Dropbox.
Share content. Then after share your screen.
There is no option for share screen. Okay. I'm not getting share screen option. Wait a minute.
Darshan?
Hello.
Can I help?
Yes, sir.
If you want, I can show my presentation, which is the
Sir, wait a
last
minute.
one, and then later on Dr. Kalpesh can come back, sort out.
Sure, sir.
So with the permission of the chair, can I do that?
Yes, Ashwani Bhai, you can go ahead.
Sure. So we've had a very nice talk by Dr. Shah, and I really enjoyed. And he has shown that how, the drugs work, the tirofiban and the cangrelor. I'd like to put forward why I think cangrelor is. This is my disclaimer, and I'll go with the practical scenario, and the practical scenario is very clear. I'll show you. This is a patient taken up for angiography, 54-year-old lady, but just 48 kgs. And this lady, we did an angiogram, and this is, we did an angiogram and found lesions in the LAD and RCA, did angioplasty, shifted back to the CCU. But then again, in the CCU, just after minutes, patient had severe pain. We took the patient back, and this is what we found. There's the stent thrombosis just beginning to happen in both the arteries. This patient was subsequently treated and did well. Another scenario, patient came with acute anterior wall MI, like the case we have, and the proximal LAD preloaded with crushed ticagrelor, which is a standard choice and my preference. And this was the initial blockage in the proximal LAD, opened up nicely. On the table, patient after 5 minutes had a ventricular fibrillation. We did a check angiogram. This is what we found. Found a thrombus. And then this happened with grelor, which was given crushed. Another case, 65-year-old male, long-standing diabetes, came with chest discomfort, ACS. He was loaded, taken up for coronary angiogram. No, this is an angiogram. Look at the triple vessel disease. Look at the left main, LAD, proximal circumflex. The RCA was the culprit. So what does it mean? It means very clear that the present set of medication which we are using, the oral drugs, probably still have something lacking. And there's a huge unmet need in the PCI patients. Many agents are available, but still there is a problem. More and more patients are going to cath labs sooner and sooner, and there is no doubt that the P2Y12 inhibitor activity is important, and it's still a challenge. There is limitation even with these drugs which we are using. Definitely prasugrel, ticagrelor are better drugs, but then the challenge persists. And what about those going for surgery? Still, we are not sure. Many of our friends are loading before, some are even loading after. So many things remain yet to be established. We know, we are giving prasugrel, we are giving ticagrelor, but look at this one study which showed that even after giving these two drugs, many patients would not achieve complete platelet inhibition till 1 or 2 hours. So what is the choice? How do we bridge the gap? Early administration if possible, high loading dose, not possible with prasugrel, ticagrelor, crushing the tablets. Yes, we are all doing that. IV therapies, GPI and cangrelor. So let's see what the evidence says. Many patients of acute MI, like our patient who has come, may be in cardiogenic shock, may require, maybe sedated, could be vomiting, like what happened in our patient with acute MI who had a ventricular fibrillation. Unfortunately, when I got to ask the patient and the attendants, and what I found out that the patient had vomited. So he was given crushed ticagrelor, and in the way to the cath lab, the patient vomited, and the ticagrelor was out, and that's what happened. And the patient landed up with acute stent thrombosis. So this is not uncommon. In patients would not be loaded properly and would not achieve the adequate platelet inhibition. So definitely oral P2Y12 may not be a feasible option in many patients. What about cangrelor? Dr. Shah has shown a couple of slides, and he has very nicely shown that how cangrelor has certain advantages. I've been part of this Champions trial a couple of years back and did number of patients with good results. And this is a novel drug, intravenous drug, and it works very fast, rapid onset of action. Within 5 minutes, in fact, you achieve a very good inhibition. And when you switch it off within an hour, most of the inhibition is gone. No dosage adjustment is required in renal and hepatic impairment patients, high bioavailability, and no drug-drug interaction. Case number 3, where I showed a triple vessel disease patient who had an ACS. And now this was the patient where we just did a plain balloon angioplasty of the RCA and referred the patient for CABG. This patient did well just because of cangrelor. Imagine had we given ticagrelor and then doing a plain balloon angioplasty, waiting, and then sending a patient for CABG. We have to wait and get into trouble later on. So let's look what is the evidence. What is the clinical evidence? The efficacy and safety of cangrelor in patients undergoing. The study has been studied in major trials, more than 25,000 PCI patients in 3 trials. Champion Phoenix platform and the PCI champion. And we know, that the PCI and platform did show a reduction, but they did not achieve statistical significance. It was only Champion Phoenix which showed a statistically significant reduction. And that was the reason that caused the advantage, and that's why it came to be approved by the US FDA. And what it showed in the meta-analysis was there was reduction in death, MI, IDR. Shown by Dr. Shah, and this is something very interesting. I like to show here. We know the role of GPI is now being questioned. And why it's been questioned? Because of the new drugs, the ticagrelor and prasugrel. And look here, what does the CANTIC trial say? The crushed ticagrelor, when compared with cangrelor, the pharmacodynamic assessment shows a much better effects within 5 minutes with cangrelor versus the ticagrelor. So what's the conclusion from CANTIC trial? Very clear. It's cangrelor, which is an effective strategy to bridge the gap in platelet inhibition. It can be administered as intravenous drug, and without any delay, you achieve a very good sustained effect, whereas ticagrelor would still require some time and maybe up to 3 hours for same efficacy as you get with cangrelor. So today, the talk and the debate is on the GPI inhibitors versus the cangrelor. So I would like to quote this very interesting study which has been published last year. And this particular study looked at cangrelor versus GP2B-3A. Now, this had both the tirofiban and the abciximab. And what do we see? This study design looked at a single center. Cangrelor was given in about 478 patients, and the GPI is in 1,594. And up to 99% of the patients. We know there are certain disadvantages of abciximab, longer acting, and I distinctly remember about 15 years back doing a very good angioplasty, large thrombus burden, and we gave abciximab. Unfortunately, the patient had an intracranial hemorrhage and died. So the bleeding events, that's the big shocker, which is there with these GPIs. The bleeding events are much more. And in this particular study, they looked at bleeding events, the clinical outcomes, in-length hospital stay, intensive care unit stay, and this is what they found. As compared to GPI, cangrelor achieved a procedural success which was similar, but major bleeding lower in the cangrelor group. The vascular complication rates, the in-hospital length of stay was significantly higher in the GPI group. The in-hospital ischemic events such as myocardial infarction, all-cause mortality, stent thrombosis definitely were the same. And my friend Dr. Shah has just shown that why he prefers tirofiban, and he also showed the fabulous FASTER study. But fabulous FASTER study definitely just is a study which looked at the platelets. It didn't look at the clinical outcomes. This particular study also showed the 30 days significantly lower rates of myocardial infarction and the target vessel revascularization in the cangrelor group. So the bleeding events, as I said, were less with cangrelor. The myocardial infarction rates were less. The total hospital stay was less. And here the cangrelor was the winner, hands down. And then there's another study, the bridge study. Now we know that bridging, specifically the patients who are going for a surgery, is a big issue. And the results of this bridge trial support this hypothesis that we know that IV cangrelor is feasible and a safe management strategy in patients who require platelet Y12 inhibition after the thienopyridine discontinuation prior to surgery. And this is where it scores over all others. So in clinical practice, there is no recommendation at present from the ACC guidelines, but there is a reason. Because most of these studies and papers have come now, but the ESC guidelines have come about and they recommend the cangrelor as class 2B for patients across the spectrum of coronary artery disease who are P2Y12 naive while going for PCI. So where is the place in therapy? The US FDA recommends as an adjunct to PCI for reducing risk of periprocedural myocardial infarction, for repeated coronary revascularization, stent thrombosis in patients not treated with P2Y12 inhibitor and not planned to receive a GPI. And also, the European Medicines Agency is very clear for reduction of thrombotic CV events in CAD patients undergoing PCI. And also the ESC, I just mentioned the guidelines. Which of the patients are going to benefit the most? The ACS spared from preloaded DAPT, clopidogrel resistant patients, CABG or non-cardiac surgery patients, to reduce the cost and need for GP2B inhibitors where bleeding is a major concern, benefit sustained up to 30 days. We are looking at intuitive in chip cases, left main bifurcation, long stents, multiple overlapping stents, bridging, and also in sick ICU where internal medicine is the enteral medicines are withheld and patient is being fed by the Ryle's tube, and also in patients where the timing of clopidogrel, ticagrelor itself is an issue. Another thing I'd like to mention here that probably if you look at the pharmacokinetics of platelet inhibition, probably devaluridine plus cangrelor could be a wonderful combination. So I go back to our case. This 45-year-old type 2 diabetes patients, anterior wall MI, 100% osteal lesion, and also lesions in the circumflex LAD. We don't know how the distal LAD is, maybe calcified, maybe bad, and maybe requiring a triple vessel CABG. There's a reappraisal going on the role of GPIs as a strategy to reduce the periprocedural complications, especially after ticagrelor and prasugrel. The current recommendations for GPI are basically two. One is the bailout use and another for bridging for selected patients. But remember, cangrelor has a faster onset, faster offset of action, with some more favorable characteristics than GPIs, especially the bleeding risk, and especially the study I quoted. My strategy is very clear. It would be predictable and fast platelet inhibition and a better bleeding risk, and it would be cangrelor. Thank you so much for your kind attention.
Thank you so much, sir. And now we'll go to Dr. Kalpesh.
Good afternoon, everyone. Am I audible, sir?
Yes, Kalpesh, go ahead.
Yes. Thank you, Kamal sir, for giving me opportunity to talk on GPI in this case scenario. And I think that was a wonderful discussion with all participants of the CardioCon 2022. So here already we have discussed about the case study. Next slide, please. So patients having osteal 100% occlusion of LAD, and my seniors has already justified about the use of the diarophyban in this case, and as well as the cangrelor in their particular view. So, but this is a case of primary PCI, so I would prefer epcoritamab as a choice of GP2B inhibitor treatment for these patients for primary PCI for several reasons. Why? Next slide, please. So I will go through the quickly about the points which favor in use of epcoritamab in this case. Next slide, please. The point number one, we know the guidelines, as Ulmilstar has already discussed about the indication of using the GP2B-3 inhibitors as a class 2A recommendation as a bailed-out therapy if there is the angiographical evidence of massive thrombus. So already the case of the case already we have a grade 5 thrombus, and slow or no reflow is a prediction if patients having a grade 5 thrombus burden. And also there is a class 2B indication as a adjuvant to a primary PCI performed with unfraction impaired. It may be considered in those without contraindication. Next slide, please. So point number two, if you look at the pharmacokinetic comparison. Next slide. So epcoritamab as compared to other GP2A inhibitors, that is a non-competitive inhibitor, and it has having a high platelet affinity. If you look at the plasma half-life is less than 10 minutes, but the recovery of platelet function will take a longer time. So that would be an advantage of using the epcoritamab if patients who requires the higher anticoagulant level or who is having a high risk for the thrombotic complication. The effect of epcoritamab persists even for 48 hours. And we should not forget about the renal function, because most of patients who is having anterior wall MI may be having an involvement of renal parameters. So in patients who is having a renal insufficiency in there, the epcoritamab will be preferred as the route of elimination as compared to GP2B inhibitor will be different. It is a vascular space, and spleen will debride the epcoritamab. So there is no dose adjustment even if required for epcoritamab. Next slide. So next is patient's reversibility. As we have discussed, it will take for 24 to 48 hours for reversibility with platelets. Next slide. Point number three, if you look at the mechanism of action as compared to other GP2B inhibitors, the epcoritamab binds with the RGD binding pocket and secondary KQ receptor, while tilofiban and iftafibatide it binds RGD binding sequence, and it will react with both latent and active state of the GP2B inhibitor. So it is therefore it binds with the non-stimulated as well as stimulated platelets, but only abscesimab react with only activated platelets. Next, so it has a potency with the only activated platelet will be inhibited. So this is a diagram which will is showing the abscessimab also bind with the other receptor which is present on leukocyte, MEK1 receptor which is present, and leukocyte which will inhibit this leukocyte and also decrease the inflammatory response in patients who is having a acute MI. Next slide, please. Point number 4, the clinical indication of axicimab as current guidelines is always recommended that selective use of axicimab for patients with high risk of ischemic event like large anterior wall MI, what we are having a case, large thrombus burden, as we know that there is a grade 5 thrombus burden in these patients, and angiographic complication, distal embolization and no flow reform for primary PCI, especially in patients with low risk of bleeding. Next. So point number 5, we know that the concept of no flow after PCI, but there is a unique mechanism of axicimab. What the no flow phenomena? When the microparticles set from the activated or dead cells which contain the pro-coagulant and this pro-inflammatory property. These microparticles from various vascular and peripheral blood cells, it will circulate in blood and accumulate into atherosclerosis plaque. So this is responsible for basics of inflammation and new thrombus formation in patient with the acute MI. While lower levels of pro-coagulant microparticles were achieved with abscesimab if treated compared with the iptafibatide therapy or primary PCI only without administration of GP2B-3A antagonist. Next slide. Next slide. So this is the concept of no-fibrillar and advantage of using abscesimab. So in particular, abscesimab has shown it enhanced the coronary flow in primary PCI by its action on platelets, leukocyte, microparticles, as well as a microembolism. Next, so there is a multiple mechanism of action which has a beneficial role of as an anti-inflammatory action. While tirofiban and iptafiban are non-peptide molecules with marked specificity with GP2B-3 inhibitors. So only abscesimab, which has a potential direct inhibition of adhesion of platelets and endothelial cells and platelets and white cell as a consequences to inhibit the or limit the inflammatory process in ACS patient, specifically after PCI. So abscesimab may suppress the rise of markers of inflammation after PCI. So there is another advantage of using abscesimab in patient with the large thrombus burden. Next slide, please. Point 6 is comparative benefits of axicimab, the longer duration of inhibition of the platelets. Next slide. So if you look at the chart of the abscesimab, tirofiban, and iptafiban, there is a duration of the inhibition of platelets will last longer. So in patients, next slide. So in patients who require having a high thrombotic complication risk, in this the abscessimab will be more advantageous as compared to the other iptafibatide and tirofiban as well as the cangrelor, because the duration of action lasts shortly in comparison with the abscessimab. Next slide, please. Point number 7, this is out of case discussion that it will promote the thrombolysis. Even patients who is having an anterior wall MI, large infarction, if it's going for the thrombolysis, the abscessimab allows the penetration of the both endogenous and parenteral fibrinolytic agents into clot. Thereby, it will promote the fibrinolysis. Next slide. Point number 8, it's clinical data. As we have shown, many trials has shown that there is an advantage of using axicimab in patients who is having acute coronary syndrome with a low dose heparins will reduce the acute myocardial primary endpoint in terms of decreased revascularization as well as the cardiovascular mortality. So main abscessimab trial studies was EPISTENT and EPILOGUE trial. There were the 3 largest trial which have been studies in many patients who is undergoing a PCI and who is having a high risk for PCI. Next slide. So if you look at the clinical benefit in terms of primary endpoints, means 30-day death, myocardial infarction, and urgent revascularization rate was achieved lower as compared with other GP2B inhibitor. If you look at the epilogue and capture trial, where they used the abscess map, the percentage of achieving primary endpoint as compared to placebo was lower, and p value was very significant. So in terms of reduction in absolute risk reduction as well as the relative risk reduction was quite achieved in patients who has received the abscesimab. Next slide. So this was the EPIC phase 3 trial where they have shown that the death MI urgent revascularization endpoint was lower in a patient who has received the abscesimab. Next slide. Next slide. So, though there was a little higher incidence of thrombocytopenia in patients who has received abscesimab, but the bleeding rates was not that much significant as compared to the placebo. Next slide. If you look at the comparative clinical data, point number 9, so there is the DREAM trial. They studied the abscesimab versus iptafibatide versus pyrofibran. All three drugs studied, and they have shown that intimal dissection and thromboembolism were higher in iptafibatide and tyrofibran treated group. Similar major and minor bleeds as per STEMI were more with the iptafibatide. So cumulative major cardiac adverse event, if you compare the tyrofibran was with the abscesimab, it was only 4.8% as compared to tyrofibran and iptafibatide at the end of 30 days. So the cumulative mesh was higher in other GP2B inhibitors as compared to the abscesimab. Next slide, please. And we know that the onset of action time to achieve 80% platelet inhibition is very less with the abscesimab as compared to iptafibatide and tyrofibran. Maybe less, more or less with the Sanglor, as we have discussed about the Sanglor presentation. And advantage of using the abscesimab in patients, because the elimination occurs in the vascular space, so you don't need to reduce the dose in patients who is having a renal insufficiency. Next, please. So, comparison and randomized placebo control trial, the risk of recurrent ischemic complication within 30 days after PCI was reduced by almost 40 to 60% with abscesimab and only 15 to 35% with the iptafibatide and tyrofibran. Moreover, abscesimab associated with the long-term decrease in mortality, well, mortality reduction has not been observed to the date with the iptafibatide and tyrofibran. Next slide. So if you look at the clinical trial, which is compares the previous absolute and relative reduction was achieved with abscesimab more as compared to the tyrofibran. So EPIC, epilogue, and capture trials, the absolute risk reduction and relative risk reduction were more as compared to tyrofibran was studied in RESTORE as well as the target trial. Next slide, please. So in target study also, the primary endpoint composite of death, non-fatal MI, and urgent target revascularization within 30 days more occur with the tyrofibran as compared to abscesimab. And targets showed that tyrofibran to be inferior to be abscesimab and not better than the putative placebo. Next slide. Next slide. Next slide. About Sanglor, as Saresh discussed the advantage of Sanglor, but most of patients who comes to the primary PCI, the Sanglor already indicated who has not received the P2Y2 inhibitor, other P2Y2 inhibitors. The most of patients comes with us with loaded with either procedural or ticagrelor. In this case, the potential interaction can be possible with the Sanglor. Point number 10. Next, long-term benefit has been shown with use of abscesimab. Next slide. If you look at the troponin level, patients who has an elevated troponin level, they will get the benefit, more benefit with the abscesimab. Next slide.
Kalpesh, last 1 minute.
Yes, sir. Next slide. Next. And comparative safety. Next slide. Though thrombocytopenia was higher in patients who has received abscesimab, but TME bleeding, if you look at the minor and major bleeding, almost equal in all three group of patients. Next slide. And adverse profile, if you look at depth of profile, the all having a cumulative major adverse outcome was equal in all three GP2B inhibitors. Next slide. So take home message, early admission of axatilimab in high risk patients, 1 year mortality was significantly lower with early axatilimab administration as compared to the lead. There is no significant increase in bleeding rate and provided better benefit to harm profile than standard therapy in high risk patients. High infarct related artery patency at the onset of PCI and higher left ventricular function at 90 days post PCI and lower incidence of heart failure. Next. And the intracoronary administration has a more advantage of using axatilimab because a higher local concentration deriving from intracoronary administration, which may lead to the optimization of both GP2B and 3A and non-GP2B-3A dependent property. Thank you. Next.
Wonderful. All three presentations. Thank you, Dr. Urmil, Dr. Ashwini Mehta, and Dr. Prashant. Over to chairpersons. Dr. Durul, I can see you. Any questions
yes,
that you have?
No, sir, I would like to highlight
Dinesh?
that all the three speakers have very well, highlighted upon. Somebody took the potency as an advantage. Somebody took it as a, as the risk of bleeding. So I would really like to highlight that Urmil sir had really stressed upon the grade 5 thrombus, the intake of P2Y2 oral inhibitors. And the next Ashwini sir has been very much telling about very well about insisting upon the bleeding risk and the profile of distal distal LAD, which might lead to CABG in that case. Kalpesh sir has also very much stressed upon nicely upon the duration of action and the multiple mechanisms of abscessamab and the renal insufficiency, which might be there in the case where it would be very safe. So all the three had been justifying their molecules very nicely.
Dr. Chirag?
Yes, sir. I want to just ask Dr. Ashwini sir, if we are using IV cangrelor, what should be the timing of switching to oral drug like clopidogrel or tirofiban, that ticagrelor?
Yeah, I'll tell you, that in the trials, the way it was done, and just after the procedure, you can load the patient, and that would be taking care of most of the patients.
Okay.
I'd like to this was a very nice sessions, and we had really enjoyed the presentation by my fellow speakers also. And Dr. Kamal Sharma, it's a wonderful conference. And let me tell you, I had the opportunity to go through the various topics. The way it has been done, it packs the punch, and it's very compact and to the point, and really enjoyed being the part of it. I think all the panelists and the speakers would agree that each molecule has its own space, has its own role. And I think there's a time that in naive patients, sick patients, there's a time to revisit cangrelor.
Yeah, completely agree. Dr. Ravi, your comments, if you have any? Dr. Ravi Bhojani?
Yes, it was a very nice session, and thank you, sir, for giving me an opportunity to be part of it. And I every time I see that whenever we don't have a opportunity to load the patient, either patient has got crashed or maybe has got intubated because of some critical event. In that case, definitely we have to go through such a issue where we don't have a proper loading of the patient with antiplatelets, and in such scenario, this kind of discussion definitely is going to help us in the managing the patient. So I am really so the cangrelor can be kept as a reserve molecule for us when we have not able to load the oral antiplatelet agent, and we can use it as a reserve molecule. I guess that is the best thing with cangrelor we have.
I think it's, as Dr. Ashwini Mehta pointed out very clearly, it's a good therapy for bridge and good therapy for short when you are actually dealing with somebody who's going to bleed or have a risk. The reason I gave moderate to severe MR here was to prompt you that maybe he'll end up with an MV repair or MV surgery, or maybe the thrombus is not cleared enough. You still have thrombus hanging, patient decompensate with MR, and you need to go for a repair. And that's why we created a reason for, cangrelor to come in. Of course, with the hope that maybe the 2B3A inhibitors would clear it off and then MR goes away. Then probably you will not need the surgery. But if I was to mention this is a severe MR, then Dr. Ashwini Mehta would have it his way. And if I was to mention no MR, then he would not have a chance to speak. So I had to keep it that way. But I think we've used it in 4 or 5 patients now. All of these patients are patients who've had history of recent bleed, patient who've done a high risk surgery, angioplasty. I remember a lady, we did a left main to LAD, 70-year-old, and there was a diagonal which was flowing well, but there was a circumflex from the flowing well across the left main to LAD, but the diagonal had TIMI2 flow, and we were worried because it was a long stent. We'd done a pot, we did imaging, we did IVUS, everything was looking good. Lady had a typical, she was restless even when before we took her for PCI. And she was frail lady, 40 kg, 70-year-old, not very cooperative, always the somebody that keeps you awake all night. And then she had history of GI bleed in past. So that was one of the first case that we used cangrelor. And we had good result. I gave it only 1 vial. And once the patient was actually out of the cath lab, maybe cangrelor worked or shifting out of cath lab work, the patient was settled. So most of these elderlies, they don't like to be in caths. So those are the case scenarios where we have used it often. But let's remember, this is an antiplatelet and that's an antithrombotic. Let's not mix up the two. If you are loading already with a potent P2Y12 inhibitor, we don't have data. We don't have data for cangrelor if you've already loaded them with, say, the ticagrelor or aspirin. That's my take. Any comments from any of you, Dr. Urmil, Dr. Kalpesh, and Dr. Ashwini?
Yes, so I absolutely agree with all the speakers and all the panelists that as far as safety is concerned, definitely we can vouch on that. It is a much safer molecule, and it is something a very, very good molecule. Just like switch on, switch off. Just you switch on, the effect starts, you switch off, the effect goes. And that is a real advantage. And I would say cardiogenic shock is going to be the main indication. And second is breach to the surgery is going to be the second most common indication, because many a times we do come across patient within 15 days, they either cholecystitis or any acute abdomen, and they need a non-cardiac surgery. And we didn't have a choice. So similar to the warfarin in post-MV or post-valve replacement patient, we have a breaching like heparin. This molecule also can work very nicely in this subset. So that is I wanted to highlight. These are the 2 very good indications of using this molecule. Thank you very much, sir.
Dr. Ashwini Mehta, any comments?
Yeah, in fact, I'll agree with what Dr. Shah said. And the point you made, Dan, let's not get carried away, and we should remember that it's an antiplatelet molecule. And the tirofiban definitely is being used also as an antithrombotic agent. So, so let's not use cangrelor in situation where you already see a thrombus. So I would be I would still use tirofiban whenever I would see a thrombus. There's no doubt about it. So like post angioplasty, I get a stent thrombosis, I would be using tirofiban. There's no doubt about it. So, but only in loading patients, when the patient is naive, there is an indication for cangrelor. So that message should be absolutely clear.
Absolutely. So I think if there are no more comments, then we can end this session. And this was the last bout in the hall.